Welcome and hello, everyone. My name is Ashley Ogodima, the President and COO at Quality Interactions. Thanks for joining us today to talk about cultural competency for patients with limited English proficiency, or LEP. I'm delighted to introduce one of our company's co-founders and a leading expert in providing culturally relevant healthcare, Dr. Alexander Green. Dr. Green has prepared a presentation for you, and after he's done, we'll answer a few questions of which you've submitted via the webinar registration form. You can also feel free to submit questions in the Q&A section during our presentation. If we have time, we'll be able to take a few today, and if we run out of time, we will be sure to answer them in the follow-up materials sent out to you following the webinar. And with that, I'll hand the mic to Dr. Green. See you all again for Q&A. Alex?
Yes, thank you so much, Ashley, and thanks for joining the session today, everyone, and really for your commitment to the issues of health equity. It's such an important topic, and we're going to have a very interesting session today. To set the stage to start and just to see where we're all at, we wanted to do a brief poll. And so as we go forward, if you could answer this question as to the type of language interpretation that your organization provides, in a few minutes, we'll have the results of that poll, and we'll be able to show you those on the screen. And in the meantime, I'll go ahead and continue with the presentation. All right. So I'd like to welcome you again to this webinar focused on healthcare for patients with limited English proficiency. Again, my name is Alex Green. I'm a physician, a researcher, and a medical educator. And I co-founded an education company called Quality Interactions, which I'll tell you a little bit more about in a moment. I'm currently practicing at a community health center in Worcester, Massachusetts, that takes care of a very diverse and wonderful patient population that speaks more than 30 different languages. I've spent the past couple of decades of my career in places like Cornell and Harvard Medical School, working on ways of improving care for vulnerable patients. In particular, I've had a special interest in the area of language barriers. And today, we're going to talk about the challenges that patients with limited English proficiency face in our healthcare system. And we'll touch on some approaches to improving their care. So my colleagues and I founded Quality Interactions over 20 years ago now, and the idea was to train healthcare professionals to do a better job of caring for vulnerable patients in order to reduce disparities and improve health equity. We offer cultural competency assessment, a really extensive catalog of interactive e-learning courses, simulated case interactions, and lots of other tools for ongoing learning. And I'll come back to this briefly at the end of the session today. So in the short time that we have together today, I'll focus on a few main ideas. First, why is this issue so important? I'll touch on some of the facts and the data about language barriers and how they can lead to poor quality of care for patients. And then we'll get into what's behind the health inequities that we see in these patients' care. And finally, we'll touch on what we can do about it. So with that, let's see if we can bring up the poll results from the question that we had at the beginning. All right, great. So it looks like very few of you, which is great news, use no interpreter or family members primarily as interpreters. A small percent, about 6%, use bilingual staff members, not interpreters specifically. 31% use in-person medical interpreters. 40% use over-the-phone medical interpreters. 15% use video medical interpreters, which is interesting because that number is starting to rise. And 4% use other means. So I'm going to go ahead and close that. So that gives us a good sense of where things are. For most of us, when we go to see the doctor, we try to explain our concerns and we try to understand what the doctor is telling us. And it's not always easy, but in the end, it hopefully works out. Well, for about 25 million people with limited English proficiency in the US, it's really not that easy. We're talking about 9% of the US population. So this is not a small issue at all. A lot of people are even afraid to seek care because of language barriers. There are miscommunications all the time, and what they do is lead to poor quality of care. So here's a map of the US, and it shows the states with the highest concentrations of people with limited English proficiency, which we're going to be referring to in this presentation as LEP. There's the traditional immigrant hubs, of course, of California, Texas, Florida, Illinois, New York and New Jersey, which account for about 2/3 of the total LEP population in the US currently. But what's interesting is that the demographics are beginning to shift, and we're now seeing the fastest growing immigrant and LEP populations in places like Washington and Alaska, Wyoming, North Dakota and South Dakota, Nebraska, Minnesota, Iowa, Indiana, Pennsylvania, West Virginia, Maryland, and Delaware. So this is an issue that we really all need to pay attention to very carefully across the nation. So first, how do we define limited English proficiency? In a way, it's pretty straightforward. In the questionnaires and the research on this topic, we usually ask a simple question: how well do you speak English? And the possible answers may be very well, well, not well, or not at all. And any response other than very well is actually considered to be limited English proficiency. It's very similar to saying that you're not fluent in English. A patient may seem to be able to communicate reasonably well in English, but still be considered to have limited English proficiency. So for example, I think that I speak Spanish very well, but I would feel much more comfortable getting my healthcare in English, which is my first language. For me, it'd just be, something where I'd be worried about something being missed in communication. So asking an additional question can actually help quite a bit with this. What language are you most comfortable using to discuss your healthcare? In some cases, a patient may not speak English well, but they may still say they prefer their healthcare in English. This could be due to a number of things: pride in their English language ability, wanting to please the healthcare provider, or fears that they wouldn't be treated as well if they didn't speak English. In any case, it's crucial to identify when patients have limited English proficiency and make sure that everyone is on board with a plan for how to communicate effectively with them. The fact is, patients with LEP receive lower quality of care and less safe care than those who speak English well. We now know from multiple studies that adverse events affect patients with LEP more frequently and more severely than they affect the English-speaking patients, which makes a lot of sense. If you can't communicate in the language you're comfortable in, errors are bound to happen. Patients with LEP are more likely to experience medical errors due specifically to communication problems, which are actually the #1 cause of medical errors for everyone, but even more so for patients with LEP. And maybe most concerning is that patients with LEP are more likely to suffer from physical harm when errors do occur. In terms of specific measures of quality, patients with LEP receive less preventive care like flu and pneumonia vaccinations and timely cancer screening. They have worse control of chronic illnesses, chronic conditions like diabetes and hypertension, and they're less likely to understand their disease and their specific treatment plans. This is a schematic that illustrates how both language barriers and also cultural barriers come together to lead to communication problems for patients with limited English proficiency, which in turn are associated with greater risk for medical errors and lower quality of care in general. So it's important to be thinking both about the linguistic side of things as well as the cultural side of things. We'll talk about a little bit more later. In some of the earlier research that my colleagues and I did, we identified some common causes of miscommunication and medical errors for patients with LEP. So these were things like using interpreters who weren't trained or qualified, using family members, friends, and staff to interpret, providers trying to get by with their very basic second language skills or the patient's very basic English skills, and sometimes not understanding patients' cultural beliefs and values, which a good interpreter could potentially help out with quite a bit. I'm going to focus particularly on the use of non-qualified interpreters or ad hoc interpreters because this is the most common way that people with LEP communicate in the healthcare setting. Patients often expect that their English-speaking family members or friends can help interpret for them. We refer to these as ad hoc or untrained interpreters. Certainly, this may seem better than the alternative of no interpretation at all, but it's a big problem for several reasons. First, and most importantly, medical interpretation requires a very specific skill set. Interpreters go through extensive training, usually have a great deal of experience with the process of interpretation as well. And doctors aren't always so easy to understand, and interpreters have to comprehend everything that was said and then quickly translate almost word for word in clear and simple terms. Ad hoc interpreters generally can't do this well at all. A lot of times they have limited English proficiency themselves, and even if they seem to speak English fairly well. So secondly, family members may have their own agendas, and patients may not be comfortable saying everything with a family member present in the room. It also can present a major psychological burden on a family member who is interpreting and also at the same time trying to deal with the family member's illness. Imagine, for example, having to interpret to a parent that they've been diagnosed with cancer. What we know from current research is that about half of patients with LEP report having no interpreter of any kind involved in their healthcare interactions. So this is quite different from our survey at the beginning, where there were a great deal of interpreters involved in your organization, which is fantastic. The vast majority of those that did involve some kind of interpreter used ad hoc interpreters like family members, not professionally trained interpreters, despite what we just discussed about the pitfalls of all this. Studies like this and others eventually got the Joint Commission to issue policy and practice guidelines to make interpreters available in hospitals. The Department of Health and Human Services has also mandated that hospitals provide professional interpreter services at no extra cost and make this clear to patients or risk losing their federal funding. So now we've gone over some of the issues. I want to present a case that shows how this can play out in the real world of clinical care. So we have here Mr. Velez, a 54-year-old Spanish-speaking man who comes to the emergency department because his belly has been distended, swollen, and sore. He speaks a little English, and he's accompanied by his 15-year-old daughter who speaks English very well. When he sees the doctor, it's assumed that between Mr. Velez's English, the doctor's Spanish, and his daughter interpreting, they'll be able to get by. And he's been constipated for a few months now and has not been able to have a normal bowel movement or any bowel movement in over a week. He's occasionally had some blood in the stool and has been losing a lot of weight. Blood tests show that he has anemia. So the doctor in this setting is very worried about the possibility of colon cancer and wants to admit him to the hospital to do some studies. Mr. Velez seems very upset and confused about this. He just wants some treatment for the constipation so he can go home and have a normal bowel movement. Initially, the doctor tries to use her Spanish to explain the situation, but Mr. Velez doesn't seem to really understand. She asks his daughter to help interpret, which she does, but she often seems to be shortening what the doctor says and having side conversations in Spanish with her father. Mr. Velez gets increasingly upset, and things just spiral from there until he eventually decides to leave against medical advice. So, what could have happened here, and what could have been done better? First of all, from the beginning, it should have been recognized that Mr. Velez had LEP and would need a professional interpreter. That could have been identified when he first registered, setting the wheels in motion for a professional interpreter either in person or by phone or video. And this is a systems fix, okay? So this takes away the human error component that happens a lot of times in these scenarios. If you leave it up to busy doctors and nurses to recognize when an interpreter is needed and have them do all the work to call for one and delay the visit even further, how likely is it that they're going to actually do this? It's much better to make it a standard protocol. So since that didn't happen in this case, once the physician began speaking with Mr. Velez, she shouldn't have assumed that her limited Spanish and his limited English was good enough to get by. This mistake happens often in the healthcare setting, and it's equivalent to essentially accepting that a patient with LEP will have lower quality of care than English proficient patients. But at least at some point, the physician recognized that good communication wasn't happening, and Mr. Velez wasn't understanding what was going on. Instead of engaging with a professional interpreter, though, she turns to a family member to interpret, and not just any family member, but a child. And this is not only a terrible decision, but it's actually an illegal one, and there's good reason for that. Let's look at what actually happened in this case. So it turns out that Mr. Velez was actually very uncomfortable with his daughter interpreting for him from the beginning. He just didn't feel right saying anything about it. He had to talk about sensitive issues in front of her, like the fact that he hadn't had a bowel movement in over a week and had noticed some blood in the stool. And when the doctor started talking about the possibility of cancer of some type, his daughter didn't want to tell him this directly, and she became very evasive. So when the doctor mentioned wanting to bring him into the hospital to do a colonoscopy, he didn't understand why he would need that, and he began to get upset. And eventually, the miscommunication led to him leaving the hospital against medical advice. So in these scenarios, the miscommunications spiral out of control and lead to a lot more problems than that could have been avoided. So who are these professional medical interpreters that we've been talking about, and what exactly do they do? Well, according to the International Medical Interpreters Association, the primary function of the medical interpreter is to make possible communication between a healthcare provider and a patient when they don't speak the same language. In performing this function, the medical interpreter's commitment is to the goals of the clinical interview. Even when an in-person interpreter isn't available, there's, of course, remote telephone and video interpreters, as many of you use, that are available quickly and can function as useful alternatives. And there's additional roles that a medical interpreter can play. And I'm not going to get into these in detail right now, but I've done some work in this area, and it's really interesting how they can contribute to the helping of the patient and to the clinical interaction. They can go way beyond the usual interpretation of language. Here's some examples of what they can do. So now let's briefly touch on some guidelines and tips on how to work effectively with medical interpreters. There's a lot more detail to each of these, and they require a lot of practice to do well, but we'll hit on some of the highlights. So first, it's important to prepare for the encounter. That means holding a brief pre-meeting with the interpreter before seeing the patient, introducing yourself to the interpreter, and explaining the clinical situation. Next, it's important to set up the interaction correctly with the patient, the interpreter, and yourself in a triangular position, oftentimes with the interpreter just a bit behind, so that you can all see each other and see each other's eyes easily and communicate face to face. Thirdly, perhaps most important of all, is to keep your language succinct, simple, and free of jargon, and give the interpreter time to interpret what you've said, and vice versa. Fourth, just as in all encounters, it's of course important to pay attention to verbal cues and to respond accordingly with empathy and with connection with the patient. Just because there's an interpreter there doesn't mean that you can't still connect with your patient. And finally, it's useful to debrief with the interpreter afterwards and document carefully that you've worked with a qualified professional medical interpreter. So I wanted to end by sharing a new course that Quality Interactions is offering next month called Ensuring High Quality Care for Individuals with Limited English Proficiency. And this will give you and anyone who goes through it a deeper dive into all the concepts that we talked about today, and particularly the guidelines on working effectively with medical interpreters. You get to try your skills out in simulated clinical scenarios with real-time feedback, and you get continuing education credits along the way. I'm going to give you just a quick demo of one of the interactions that we have in the course.
Mrs. Ramirez, your daughter seems to be suffering from chronic recurrent asthma, which is a condition where the bronchial tubes become inflamed and obstruct the airflow from the lungs. It could be that she has some environmental allergies. Pollen, for instance, can trigger this commonly at this time of year, or it could be that she has an underlying viral infection.
The pediatrician could have improved this interaction by using shorter, clearer phrases before allowing the interpreter to interpret, providing a more thorough explanation of asthma, avoiding the use of medical jargon.
So we have a lot more interactions like that in the course and a lot of background information, and it really is a wonderful way of engaging learners and stressing the importance of these issues and giving them some guidelines on what to do and how to do it effectively. So to close the session today, I'd like to propose that we all aspire to the following 3 goals to improve care for patients with limited English proficiency. First, we need to develop systems for interpreter services that are highly efficient and effective. Second, we need to make sure that healthcare professionals are well trained to work with professional medical interpreters, which is a skill set that doesn't come automatically, but needs to be taught, learned, and practiced. And finally, we need to expand the role of medical interpreters to make them an integral part of the healthcare team. But with that, I'll close the presentation part and I'll open it up for questions.
Thanks, Alex. That was quite illuminating. I know that we have two questions in the chat, and we've comprised a list of some of the questions that you all have submitted during the registration form. And so I'll lead with the questions that we got from the registration form, and then I aim to answer the ones in the chat as well. If we don't answer them here again, we will make sure to answer them in the follow-up materials being sent out. Alex, the first question is there a study or research that has identified how LEP patients best prefer to be communicated with, an interpreter versus a native speaker?
Okay, so yes, there's been a lot of research on interpreters, different types of interpreter services versus native speakers. Clearly, it would be great if we had matching, healthcare professionals that all spoke, languages that their patients spoke. But this is not ever going to be that perfectly aligned in the healthcare system. So, but yes, they do tend to prefer someone speaking their own language, a native speaker, as a healthcare professional. But interestingly, it's not by as much as you might think. So interpreters are actually considered to be, when they're well trained and do their job well, very satisfactory to patients. They really appreciate the attention that they're given by a professional interpreter, and their experience is quite high with professional interpreters. What's interesting too is that you might think that live interpreters are always preferred I shouldn't say live, but in-person interpreters that are there in person physically versus video and phone interpreters. But actually, some of the data on well-trained phone interpreters and video interpreters show that they're almost equivalent in some cases, in some studies, to live interpreters. Other studies break it down a little further and show that different types of interactions have different preferences. So for example, some patients prefer to see a live interpreter because there are family members in the room and there's a lot of engagement and back and forth interaction, and the live interpreter the in-person interpreter, I should say, can really help out with that quite a bit. Other patients that are presenting with sometimes very sensitive issues would actually prefer not to have a live person in the room, and sometimes prefer the anonymity of having an audio interpreter over the phone. So there's different calls for different types of interpreter services as well.
Thank you, Alex. Thanks so much. The next question is, in the US, do interpreters have to get specific qualifications to interpret for healthcare versus, for example, a legal setting?
Yes, they do. In fact, that's not that old. That's been fairly recent that they have very specific certification programs for interpreters within the last 10 years or so. As far as I remember, the International Medical Interpreters Association, IMIA, was very influential in getting these certification requirements to be adopted. And so now, to be a professional medical interpreter that's certified, you do need to go through a standard course, and you do need to take a certain certification process in order to qualify. And so it's important as healthcare professionals that we're working with those kinds of interpreters that really have gone through the official process.
Thank you. How do we make this a priority for providers who are apathetic to language barriers?
Yeah, that's an important question. So, we can teach people all we want, and they may understand how to work effectively with interpreters, but if they're not really on board with the idea of how important it is, they may not do it. It requires an extra step oftentimes. It takes a little extra time oftentimes. And so we need to convince them through education from early on. So for example, medical schools are now making sure that students are learning this early on. I think nursing programs are oftentimes also teaching about the importance of language and interpretation. So getting this in early on and getting people to realize how important it is crucial. But I think, you really can never quite get over that sort of apathy until you institute some kind of formal process or systems, guidelines that make sure that this is part of the way that we do business, right? If you're a healthcare organization and a patient with limited English proficiency comes in, you have to have a system in place that automatically says identifies the person as limited English proficient and begins, like I said before, the wheels in motion for getting that interpreter there. So you're not depending on, human decision making as to, oh, does this person need one? Does not? Do I have time to do this or not? But rather, it's just part of a system and a mechanism that is always in place.
Right, makes total sense. Thank you. And then the final question from the webinar registration forms, and then if we have time, we'll hop over, is what is the best way to help medical staff understand how important it is to communicate with their patients, even when they're considered that family or friends will, know the basics of the patient's language?
Yeah, I think, I mentioned the Quality Interactions LEP course that we're coming out with in October. And what I didn't mention about it is that course is not just for clinicians, it's also for non-clinical staff, really all levels of healthcare professionals, because it is so important that everyone realize this and not just the clinicians. We need to bake this into our system so that each professional knows their role in terms of making sure that we're working effectively with interpreters. It may be, someone talking to the patient about their insurance status, which is, very important. And we need to make sure that they're aware of these issues as well, and that family members are not always going to cut it.
Thank you so much. I'll hop right over to some of the questions here. I do see that we have a few of them, and so I'll start kind of in order, the ones that jump out. One question was, where can someone find the information on the LEP population for their state? Like, where
That's a
might
good
someone
question.
start with that?
Yeah, so states are different in terms of how they interact with, the LEP population and the services that they have available. I would go to the Department of Public Health probably at your state. They usually are the ones that are, keeping track of things like the statistics and resources and that sort of thing. That would probably be my Department of Public Health for the city or state that you're part of. You can also go to the national sources, Office of Minority Health, Department of Health and Human Services, and they may have some additional information as well.
Awesome, thank you. There was a question around how long the course takes right now for the new LEP course coming out next month, and that answer I can take for you, Alex, is about 1 hour. It's a one contact hour. And we're right at 12:59, and so I will close us out, but I will leave you with the promise to get to as many of these as we can in our follow-up materials. We really appreciate your time, Dr. Green, today, as well as those of you who joined us on this call. We will follow up with any unanswered questions, as I stated, and any follow-up materials that we can offer. Thank you so much. You will receive this video recording from today's session in the next day or two with some special offers for our new LEP course when it's available. Take care and have a great rest of your day, everyone.
Thanks, everyone. Bye-bye.